Okay, great. Okay, everybody, thank you for coming to our swag event tonight. I'd like to introduce Ms. Iyer. She is a psychotherapist and psychoanalyst in private practice. She's attended the University of Chicago to complete her graduate degree in clinical social work, and subsequently she completed a fellowship in advanced psychodynamic theory. She currently trains and practices psychoanalysis with the Chicago Psychoanalytic Institute. Ms. Iyer has a strong interest on the impact of vicarious trauma on service providers, and as a result, she has developed Thriving in Residency, a psychoeducational program for medical residents to learn to cope with various trauma. And so with that, I'd love to introduce you guys and give her the floor.
Thank you. I'm really excited to be here and do this presentation, and also hope we can have some discussion along the way, or also at the end. I'm going to start sharing my screen as I pull this up. Give me just a sec. Let's see. Okay. So this presentation is going to be on the culture of medicine and its impact on the physician's mind. So as Aquila mentioned, I'm a psychotherapist and a psychoanalyst in private practice. I primarily see individuals, some couples and families. And in my practice for a long period of time, I was seeing actually a lot of medical residents. And this program really came out of my work with them because I realized that they needed a lot of support, but didn't always have the resources, especially with time constraints and energy to actually come to therapy. So this kind of came out of giving them something that they could do at home that's, would teach them about, especially post-traumatic stress in medicine. So this will be like a part, I've incorporated some parts of our program into this talk, and hopefully it'll spur some curiosity and interest, and we can sort of discuss some things. It's really systemically based. I'll start out with talking about the culture and history of medical education. And I do this because I think it's really important to build context to understand what we're feeling and what we're experiencing. Because without sort of historical and systemic context, thoughts and feelings and internal experience can feel lonelier, and it can also feel confusing. So I think history is really important in understanding what's happening within us. As we move through that, we're going to touch on difficulties encountered specifically by underrepresented populations. I think in particular, we'll touch a little bit on like microaggressions around race and gender, and how that's in some ways baked into the system of medicine, and then as we move through that, we'll talk about how to manage maybe your reactions to that. And that's where we'll talk about some coping strategies to cope with sort of the more intense feelings that can emerge. And then throughout, I'm going to have some quotes that come out of some research from the ACGME, that it's survey research of medical residents. And they've given some sort of qualitative statements that I found to be very, very illustrative of some of the topics I'll be talking about. And then we'll just leave some room for questions and discussion. I'll try and stop along the way and check in with people for any questions, but I also just welcome if you guys have questions, feel free to ask. We can make it a discussion along the way. Okay. So I'm going to start with this quote from Sir William Osler, who I guess is considered the father of modern medicine. And I start with this because I think it's a good illustration of, I think, how the system was constructed. So he said, "What about the wife and babies? If you have them, leave them. Heavier are the responsibilities to yourself, to the profession, and to the public. Your wife will be glad to bear her share of the sacrifices you make." So, of course, this was, probably over 100 years ago. However, I'm not sure that the system has really adapted all that much from, where it was constructed. So this was certainly the mentality at that time because the large majority of people training were men, and they probably did have wives taking care of their families. But I think the system hasn't necessarily made accommodations for the changing diverse population of physicians that have come in over the last century. And I'm going to show a qualitative quote next to illustrate how this is still happening. Um, so this is a quote from a resident. I believe it's 2015 data. And this person said, "My residency experience has been horrible. It's been filled with racism and sexism. Sorry, I can't say this. With attendings that feel that women should be barefoot and in the kitchen." This is a direct quote from one of them. "They also feel that minorities should go back to where they came from, and they have little interest in educating residents that are not white males." Of course, this is an extreme quote, and probably you won't experience something so overt and direct. But the fact that this exists and there are other qualitative quotes like this tell us that the system hasn't necessarily shifted to accommodate the people that are actually training. And the mindset is still, and I think the sort of the mindset is still designed for men, and it still kind of carries over through uh, different training programs. And sometimes I think very rarely it's this direct, but I think you can still feel the pressures there. This next piece is going to be the Flexner Report, and this was came out in 1910. And this solidified Johns Hopkins as really sort of the center of all medical training in the United States. Um, and as a result, I think medical schools began to focus almost exclusively on biological sciences, and really hospitals became the center of everything. So you could really only train if your school is attached to a hospital. And you might be thinking, well, I was thinking, well, what's really the problem with that? And because that's where there are patients. So as a resident, you would really need to be attached to a hospital. But I think prior to this, there were medical schools that were freestanding, that where people would then go to the hospital that were separate and go see patients and come back. And this was important because a lot of those medical schools that were freestanding closed after this report. And that's where a lot of Black doctors and doctors of color were being trained at the, this is 1910. And I think the result of this is that early on at the turn of the century, it sort of forecloses the opportunity for minorities to become physicians, becomes less accessible. And I think that has rippling effects through generations. And you see, I think, entire minority communities not probably getting the, appropriate medical care historically. And as a result, I think the system not only closed that door, but also, I think, created a situation where it's very difficult for minorities to travel through their training programs. And in fact, there's actually a conference that meets yearly called the Beyond Flexner Conference, and it's a group of physicians that try and meet to address racial disparities in medicine that stem from this early systemic, I think, report and decision. And this is another quote that also from the same research. And this is an illustration of I think, how this still carries over to today. So this is the new department chair is racist and prejudiced against anyone not of his own race and gender. He's fired faculty that care about residents and teaching, who are, I think, women and minorities, and hired new faculty that are his friends from the past and of his own ethnic and gender demographics, who are not nearly as qualified. The overall change has been extremely disturbing and ruined my residency experience. And I think this is unfortunate because this is an example of how, this sort of early structural thing, I think, still carries over, but is also, this is sort of an insidious way in which people are iced out and kept out. It's not as overt as the last quote. And yet it has, I think, dramatic impact on not only those training and how they feel about themselves, but also probably the larger community in that area and what kind of access minorities have. So I want to touch on historical changes in medicine because, that was 100 years ago. And yet, there have been a lot of changes, and I'm not sure how much the system has adapted necessarily, but I guess we can talk about that together. So of course, there's been an increase of diagnosable diseases, and as a result, an increase of treatment options. The US population has aged significantly. And as a result, there are several comorbidities, and to deal with all of these, people are specializing. And I think that's fine, but certainly I think there can be a feeling of when is it enough when you're training, and how far do you keep pushing yourself? Of course, costs of education and hospitals, administration, provision of care, everything increases. And I think one thing we don't mention here is that the interaction with managed care and insurance companies also drive costs up through the roof. And this makes just treatment very expensive and training extremely expensive. And to make sure that this is all done well, I think we rely very heavily on metrics and try to sort of numerically assess whether this is going right. And that can be useful, but I think it's limiting because some things are just not very easily measurable, like bedside manner and the capacity to connect with patients, even so physician well-being. And that's important because when you're not well, you can't provide good care truly. And those things are not easy to measure. And I think that gets left out in this. Another thing, as we've been talking about, is the diversity of not only the physician workforce, but also the US population has changed dramatically, which means that we're probably seeing all kinds of different clinical presentations, which may or may not be, it's hard to say whether the system's really adapted for all of these changes. So the question is sort of like, what's the impact on medical education and on your experience as either medical students or residents? One thing I touch on is that in our course is around trauma, and part of why is that the healthcare system is charged with dealing with, I think, very complicated populations, especially residents. And especially through ERs. And so you're not only going to be seeing patients who are dealing with multiple illnesses, but also you're going to be seeing sort of the underbelly of our society, people who are really struggling. And the limits of what can be done in a one-time visit, are actually severe. So I think this exposure can be wearing on the mind of the physician. I think it can be overwhelming, and it can sometimes be demoralizing, especially when it's not talked about and when it's not processed. Along with this, there's sort of a lot of increase in pressure on physicians from hospitals to stay financially solvent. So hospitals really push their own revenue constraints on physicians to keep going. And this really does, a lot of it does impact residents because your labor and residents' labor is a big part of how hospitals function. Of course, the pandemic has made this all more complex and intense as it has for everything. And I think what people expect to see, especially people in medical education, is that all of the elective procedures that were put on hold early in the pandemic are going to come back with the force, not only because people need them, but also because hospitals need to recoup the revenue. And so probably by the time you all are in residency, you might be continue to be feeling the aftermath of, and hopefully the aftermath if this comes to an end, of what we're living through at the moment. The other piece I want to touch on here is that faculty I think we're seeing more and more faculty burned out. And they generally have sort of fewer resources. And part of that, I think, is probably the pandemic and everything that's happening. But I also think it's becoming more culturally normative to talk about anxiety and depression in medicine. Slowly, maybe very slowly, but it's happening. And I think as it's happening, you're seeing more people stepping back or not as accessible, and they're more open about it. This is important because as a resident, you're going to be you're going to be in a system that's dealing with all of the things that we're talking about. And it's not so much to overwhelm you as much as it is to build context for what's happening. It's not that I think anyone's intending to make it so fractured and complex, but that's the nature of the work. And to go into it with that mindset is going to help us normalize some of the intense things that occur, basically. Let me see. Okay, before I go into this, any thoughts or questions, anything come up? I could keep going, we could talk later. Okay. I can go ahead and keep going and we can discuss a little bit later. So I brought this this little sort of statistic. This is from the AAMC graduation questionnaire. And so I collected, this looks like it's showing, medical student reports of feeling humiliated. And I bring this up because a lot of what I hear in my practice, and I think what research shows about medical students, residents, and physicians, is that part of what really affects their mood are experiences of feeling demeaned, humiliated, invisible, belittled, and things that really impact their self-esteem and their sense of agency and capacity. And I think I know humiliation is kind of an intense word, but it's reported a lot. And so I think it's important to acknowledge it. And it comes, as you can see, from multiple sources. And I think it's a big part of why, I think it's a big part of imposter syndrome, and it's a big part of why it's hard to feel sometimes confident, even though people are doing some pretty incredible work, despite the realities, let's say. So there are several factors affecting medical student well-being. So some of this is from actually, a little bit of this is from our program. We postulate that, so the things that are going to make you a really good physician, like being caring and compassionate and really hardworking, focused and productive, as well as that, that we also know that many of you are delaying, pleasure and gratification. And what we mean by that is that most people are training to be physicians in their 20s and early 30s. And that's the time in your life where most of your peers are probably, many of them probably working 9 to 5s, maybe they're getting married or having kids, or I don't know, going on vacation, just like traveling, I don't know, they're doing all kinds of things, right? They're being young adults. And we know that you're putting a lot on hold to do what you're doing. And it's important, but it takes a toll. And along with that, I think we're aware that you're in clinical environments that are disempowering by nature. They're systemically complex and flawed. And so we want to hold these two things as something we're aware of. And part of why we say that is because, as a resident, although you're on clinical teams, you may not always feel like you have a say or an impact. And that feeling, not feeling qualified or heard, can really affect imposter syndrome. It can really affect how confident and capable you feel in your job. And so, a lot of what we hear is that, you go in with really good intentions, you're putting a lot on hold, and then you're dealing with this system that is, that can feel like it's beating you down, at the time. And we want to make room for that experience. We don't want to just shut it down because it's real and it matters. And if we make room for it, we can figure out what to do with those thoughts and feelings. Okay. So we're going to switch a little bit to some of the issues in medical education. Some of them are that, just getting in and going through sort of excludes a lot of people because it's so heavy on very specific criteria and standardized testing. And there's a lot of research that shows that that's not a great measure of intelligence because of a whole bunch of cultural things, as well as that people learn and have different types of intelligence. And that standardized testing really narrows who can get in and even stay in. And a lot of medicine is focused on testing. And so, although people test well, then they have to go and treat patients and interact with other humans. And it's a whole other complex thing. The system also doesn't really accommodate much, right? So it doesn't accommodate well for disabilities. It doesn't accommodate well for pregnancy, which is not a disability, but I think almost is treated as one in medicine when you're training or if you're a physician. Doesn't accommodate for people who are parenting. And I think what happens is with resident patients of mine, I see several people putting life on hold. And then I see another subset of people not putting life on hold and going for it, but then they're paying the price because the system is not going to necessarily, make room for that. So they're working all day and all night for whatever the years they're in there. And it's just not a very forgiving or humane way to train people to take care of others. I mean, that's your job. There are, of course, sometimes very explicit forms of racism, sexism, and homophobia. Some of that we saw in the quotes. But sometimes what I'm more concerned about are the microaggressions and implicit biases, because those are harder, they're less concrete, and they're harder to pin down and really speak to and address in work settings, but yet they're everywhere. And I'm going to pop up a couple of examples of them. And one is, like female physicians being considered nurses, not being treated like their male counterparts. Another is, I think this happens a lot, are people of color being assumed to be ancillary staff and not physicians. We see this a lot, both from patients and from, I think, hospital staff in general. And this is tough because it's hard to very directly address. And sometimes microaggressions and unconscious biases aren't even very specific things someone said. They're just more how you feel after you interact with somebody. Do you feel less than? Do you feel like you don't belong? Have you been left feeling like stupid, or what are they communicating to you implicitly? And it's such a complex thing, and I think we're going to be dealing with this for a long time in this country and in, I think, many professions. But I wanted to touch on it. So this is the last quote I'm going to share, and this is a good example of how microaggressions impact the mind of somebody. So this person said, as a person not from the region, I'm not a big fan of the culture of this place. I have to move this. Oops. I can't see what it says. It says, so it makes it particularly difficult for me to find a place of comfort. I'm also a Black female, and I often battle with sexist and racist thoughts and comments from staff and patients. Comments are not new to me per se, but it emotionally and mentally drains you. It becomes a battle with so many layers of resistance and disrespect. Lastly, the area where sorry, I can't read it because there's something blocking it, but it's dominated by the hospital itself, so I feel I can never escape it, which for me is very draining. I like this quote because it's speaking to the emotional and psychological exhaustion of experiencing uh, projections from other people, like experiencing other people's discomfort or their implicit attitudes. And I think I think for a lot of people on the margins, they not only have to navigate this really difficult training experience, but they also emotionally and psychologically carry the weight of the unconscious aggression of the system and of our culture and of our society. And so it's sort of like a double burden to do both and to sort of go through a very complex training. And so this is, I think, a very difficult thing to address directly. And I think that's the hardest part of microaggressions. And I think it's something that is best addressed through conversation and discourse. I think I'm touching a little bit on internalization, and I'm going to talk more about that. So we've been talking about a lot of negative cues in the environment and in the system. Like I've been saying, so individuals that are underrepresented in medicine can feel held back, not taken seriously. And these messages that they get from the outside, maybe they consciously say, I'm not going to deal with this. But on some deeper level, when you're told something over and over and over again, it starts to sink into sort of an unconscious space where it becomes a part of yourself in a way that is hard to recognize. And people start holding themselves back in different ways. Maybe they're less vocal, maybe they don't, speak up, whatever it is. And we see this a lot with women and minorities who generally experience a lot more imposter syndrome. And I really think a lot of that is because they're taking in these negative messages from their environments. And that's not their fault. I think this is a part of what happens to us as humans. But our job is to sort of notice it as it's happening so we can do something about it. So this next piece I want to touch on is that when we internalize the negative perspectives from outside of us, we do it on multiple levels. And right now I'm going to just talk about the conscious and unconscious ways that I've seen people do it. When I see conscious internalization of negative stimuli, let's say, it looks to me like patients who come in and they're very angry, they're sad, they're having more intense feelings, they're upset. They say, I don't feel seen, I feel invisible, I feel disrespected. They talk about a lot of self-doubt. And there's a sense that they're always trying to prove themselves, but despite not having anything negative happen, they don't quite feel like they ever get there, let's say. These are ways in which these patients of mine are aware of, they're having very conscious thoughts and feelings of the ways in which the system affects them or people and their actions affect them. The next piece is sort of unconscious ways this shows up. So I often see when people can't cope with those intense feelings or make use of them or be able to address it, they start withdrawing. And I see this a lot in physicians, but I think I see it a lot in high functioning professions or high demand professions. When they can't sort of sort something out, with whoever they're having a problem with or whatever they're feeling, there's this withdrawal into themselves. And they start withdrawing from superiors, from teachers, from peers in one way or another. And they, I think, also withdraw from close relationships. And there's a lot of sort of exhaustion that comes with that. And I think that, when that happens, it's important to start to pay attention to it and be aware of it. And so sometimes connected to unconscious experiences is that when thoughts or when feelings can't be held in a very conscious way, like when it's hard to say I'm angry or I'm sad or I'm really hurt, let's say, what I start seeing is sort of bodily responses. And so the way I would think about that as an analyst is that a thought or feeling is really intense and it feels really too much to bear. And so it goes into the body, or meaning not like it goes into the body, but it basically, the stress is held in the body. And the way the stress is held in the body will show up in different ways. But the three most common that I see are GI issues and headaches, and especially fatigue. So fatigue's a really common one. And it's hard to sometimes parse whether, the residents are so exhausted anyway. So it's, how do you know if it's just the fact that you're not sleeping? But it could be. I think that's part of it. But I think it can also be like, I'm so tired and I can't stop thinking about this thing this attending said to me. I don't know why I'm ruminating about it. I don't know why I'm so tired. And it's like, they're probably related. So we want to start thinking about what we're fixated on and what kind of symptom is correlated with that, if that makes sense. And then this last bullet point I think is important because I want us to hold on to some parts of this, which are that these things that I've put here, which are sort of when you start noticing mental fogginess, like it's hard, like you're thinking and you're functioning, you're moving through your day, but there's just this kind of like fog to everything. Or you start feeling frozen or numb, or really overwhelmed. These are, just something to track and keep, in check, because they're the beginnings of depersonalization and burnout. Okay. So and I think everybody experiences all these things at different points. It's not uncommon at all. But when it gets really intense, and this is like all of the time, that is when you're really like heading deep into burnout. And so you want to just keep an eye on what's going on in your body, what's going on in your mind, and are these the things that are coming up? And if so, what can we do about it? And that's kind of the question we're going to start asking ourselves. Okay. Let's see. Okay. So we're going to talk a little bit about how do we manage all of this. I've said a lot of things. And these are three things that I do a lot, and I think are a big part of what helps in when we're working in systems that are really high stress, really demanding, and not designed to meet our needs in any way. First, I would normalize and validate your reactions because they're human and they're real and they matter. And people are not going to tell you that in medicine. Second, recognize the forces that are at work. And that's all the systemic stuff I just talked about, which is that this is not happening just to you in a vacuum. It's happening in a system that is flawed and complex. And so you're traveling through it and you're going to have all these reactions because that's what anybody would have. It's a normal thing. And with those two ways of normalizing, we can talk about what are you going to do about it and how do we manage it? Like thinking about constructive actions to take, let's say. So when we talk about normalizing and validating, so this is what I was saying. So the culture of medicine is very difficult for everyone, even people that the system's designed for. It's really difficult work. It's high pressure, high demand, and it's even harder for people on the margins because they're carrying the weight of the past and everything that's being projected onto them. you're also at the same time doing really, really important, extraordinary work that is very important in the world. And it's likely that most of you have a lot of passion and are very driven to do this. So anything that we're passionate about, we're going to have intense feelings about as well. Um, and the thoughts and feelings that you have at a given moment are completely normal and human. And we don't need to shun them or feel like we cannot have them. I think that when we do that, we start repressing feelings, and that's when we get into um, burnout. Really, I think when you start pushing your feelings away and making yourself numb is when we get into trouble. So next, we want to sort of recognize what's happening in the moment. So again, oppression can be very explicit, but largely, I think, especially in urban environments, and it's very implicit and it's insidious and it's sort of everywhere. And I think it affects how we feel in a deep way, and especially if we notice it. We may be able to, I think one thing that we can pay attention to is, are we feeling sad? Are we feeling angry? Sort of daily check-ins with what you're feeling inside and what your body's doing and what it's telling you are important. It can also sort of, be important to take time to recognize sort of the impact of everything that you're doing. Sometimes, especially with something that's so high stress, and especially with caregiving, like, so you're providing care to patients, people push through. I think that's very common in fields where there's service providing to care to patients, is like, because you're really organized and focused on the other person's needs, and people push through that day. And it's really at the end of the day that we see a lot of physicians falling apart, where they're really tired, they do not know why, their emotions are all over the place. And I hear a lot of people up really anxious and with racing thoughts. So at that time, it's really, I think, a useful time to ask yourself, what's going on? What am I ruminating about? What is my mind stuck on? What did that person make me feel? What is it stirring up in me? And finding ways to make meaning of this chaos is going to start grounding you in what you're upset about. And as you find meaning, it's going to stop making that racing happen. Things will slow down, basically. So this is what I was talking about. And yeah, I think overall, it's just very important to track and notice. When we stop tracking and noticing, things will move along, and then it catches up to us later, basically. So the last piece we're going to talk about is choose your course of action. So the first bullet point here is act or respond in a neutral or positive way in the moment. What we mean by that is, when there are really strong emotions, it's easy to say something or to confront or to do something that maybe is not the most useful. So it's okay to take time, to notice, I'm feeling very dysregulated. I'm having a lot of thoughts and feelings about this. I'm going to just take a minute and think about it and come back to the situation. It's okay to tell yourself that. And I think the other thing is, you can employ all the coping mechanisms that I know probably many of you have. I know a lot of people are doing meditation and yoga, and I think reaching out to community and talking to people, and a variety of things like good sleep and a good diet. Those are all, I think, general things that I know wellness programs in medicine are telling people to do. But I think those things are more useful when you know why something is happening. When you have a sense of, this is why I'm feeling like this, now I'm going to use these coping skills to kind of calm myself down, or to figure out what I'm going to do with it. And then also, if there's a more extreme incident, it's really important to report it if you feel comfortable, and finding advocates and allies that can help you do that. So that's it for my lecture part of it. And I just like put up some questions that I thought might be useful based on some of the feedback you know around sort of gender and race, or we can just generally talk if people have like thoughts and questions. I'd love to just talk as well.
I have a question for you. First of all, thank you so much.
Oh, sure.
This is information I don't think that we've really received before, and I would love for this to be part of our curriculum somehow. So thank you.
Oh, absolutely.
One thought that this made me think about, recently a colleague of mine who's a medical student at Rush showed me a video about maternal mortality in the US and the higher rates in the Black community, in communities of color, and how she, as a Black woman who hopes to get pregnant at, someday, that's really scary to her. And of course it's saddening. And so I'm wondering how you've seen it impact medical students and residents going into a profession that doesn't serve the identity that they share or the communities that they come from.
Mm-hmm. So, like, how can residents or if medical students or physicians be? Is it a question about how can they be aware of that sort of thing, that there is a high mortality rate for Black women, or is that what you mean? Like, how do they treat that population?
I mean, like, how have you seen it impact people emotionally, being, for example, a doctor and being a Black woman and being around colleagues who don't listen to Black women when they complain about pain or symptoms like that? How does that feel for them, or how does it impact them more deeply, I guess? And then how do they navigate that, or how do you suggest they navigate that?
Yeah. Well, I think there's a lot of rage, so which makes sense, because when you're not listened to and you feel disrespected and not heard, there's going to be a lot of anger. So patients that I've had from, let's say, like the Black community who are also in medicine, I think they're navigating, most people are going into these systems expecting to be disrespected and not listened to and not heard. And so one way that I think one way in which people navigate that is to stay extremely active and vocal and present. And so I often, when I work with patients in that way, I often make space and room for their anger and frustration and grief, because the devaluing of Black bodies in this country is profound and deeply historic. And so I think it ripples through systems like medicine and all systems, and this is one of the ways. And so we ground in that reality, and we speak to it because it's true and we see it happen. I think even like 2 months ago, I saw a Black doctor who was pregnant who died, and there was no I don't know the exact specifics of it, but it just seemed insane. And so first, really the big piece of it is not denying that to be a thing. I think it's really easy to quickly deny someone's reality when it's not our own. And so the first thing I do, and I think I encourage people to do, is really to validate and stay present with what someone's reporting. And as we do that, then we empower them to have a voice and continue to keep their voice. The flip side of that is, I think I sometimes see women of color sort of going silent and quiet as a result of, I think, largely fear of, fear of, I think, backlash sometimes, or fear of enraging people or disrupting the status quo. And in those cases, I think, they're in some denial about the system, because that's how they've learned to navigate it. To navigate such a hostile system, people go into denial and really merge with or go along with what's expected of them. And so sometimes what it takes is helping them start to tune into their own beliefs, and that takes some time, that takes some psychotherapy. And as they do that, sort of strengthening their capacity to be active. Does that make sense?
It does. Thank you.
Mhm.
Hi.
Hi.
Jess, I just also wanted to thank you so much for talking about all of this. I was talking to some of my friends and it literally feels like, wow, all of the things that I've always thought about, like, are finally just like out there. Like, you know, it's a way to just like have other people understand like how we feel as minorities. But then also, just something, I have a question. So I know this is an issue not just for like Hispanic physicians, but I know that like definitely, especially like Hispanic women, like in medicine, as like what you were saying, they can mistake them for like somebody that's like working there or something. And I think this can happen a lot for like asking you also like to translate for like whatever reasons that you know that you're needed. And there's like that conflict between like, oh, I want to like help my patients or like whoever is there, like I want to be helpful, but at the same time it's like you're the physician, right? And it's like you don't want, I don't know, and it's like I'm not here as an interpreter, like I'm a physician just like anybody else. And so yeah, I was just wondering if like what you think about that.
Yeah, that's such a tough one because I think sometimes it's hard to not feel drawn to, especially helping people from our own communities. You know, like I think it's easy to slip into that role for multiple reasons. Um, but at the same time, what precedent does it set for the staff and what they ask of you and how they think about you and how they treat you? I think that's such a complex thing to navigate. And the first thought I had was that what comes up for me when I heard your question is thinking about how do you set boundaries and command respect, you know. And I think setting boundaries is a form of commanding respect, you know, when we think about social interactions and interpersonal interactions. And so this is a challenging question because sometimes boundaries can feel firm and rigid and really distancing and cold. But I think other times there are ways in which to do it where it can be kind and also sort of commanding some amount of distance and protecting your own time. So, and I think it really depends on where you're working and what the dynamics are. But one way I would think is to, you know, check in with, do you want to interpret in that moment? And if you do, how much do you want to give to that scenario? And when do you want to set a, you know, create a boundary around it? And how do you want to be spoken to by the people who are asking that of you? And I think thinking about those things is going to help you facilitate how you interact with um, the staff around you, and that will help them learn how to respect you as well, you know, or anyone, you know. Does that make sense?
Yeah, no, that makes sense. Thank you. There was just an article that I saw this weekend about like how a lot of like female Hispanic physicians were taking on the role of like an interpreter, and so a lot of their time was being used for that instead of like actually patient care. But yeah, that's a good point. Like just thinking about how to set boundaries and just like say it in the nicest way possible, I guess.
Yeah, yeah. Any other thoughts or questions or? Trying to see if I can get this. I wonder, let's see how much, I have 8 minutes. Um, do any of these questions draw your attention or anything come up about anything you're reading here? You guys can see the screen, right?
I think, sorry, can you hear me okay?
Oh, yeah, I can.
Okay, great. Thank you so much for your talk. This was definitely a breath of fresh air and something like everybody said that we don't have in our curriculum. I'm sorry, my dog's making noises right now. Your squeaky toy. But so the question about like when you're confronted with an implicit or explicit bias, just like generally something that comes up for me is how like medicine is so hierarchical. And I can't think of a concrete example of like encountering this type of bias, but I feel like the hierarchy of medicine kind of makes it so that you can't talk about these things when they do come up. And I don't know, I feel like that's definitely a cultural shift that we need to work on, and like empowering people like you're doing with your program to like talk to our higher ups and superiors about these things.
Yeah, I think that's such a good point, because I think there's sort of this culture of fear probably that drives a lot of, I think really a lot of professions, but I think certainly drives and a profession like medicine, um, that I think that would make any grievance hard to air, but certainly one that's rooted in implicit or unconscious bias is almost impossible to speak to sometimes, because it's what you feel in yourself when you leave an interaction, or it's what you feel in the nuanced or subtle ways someone communicates to you. And I think that is going to take time to really unpack, probably over the course of your careers. Since you all are here sort of curious and interested in this, you'll probably find ways to address this over time. But yeah, I agree. I think that it is hard to address it with the system. And I think there's a slow change toward thinking about these things as our larger society is also grappling with it.
And sort of just like say a little like what Vidya was saying, that's a really good point, especially when your slide about like humiliation, because like I don't think we ever call it that, but I don't know any other field where like it's okay to like be treated badly. And like we've even had some lectures where you'll just see like it's a joke, like physicians laughing about like, yeah, you'll just see when you're like an intern or resident, you just have to ask them what they want because it's gonna change and you just have to like take it. And it's just like, so it's just like, I don't know, it's like interesting that it like, I don't know any other field where like it's okay, like you just have to expect that they might like treat you badly. So I like that you like called it for what it is.
Yeah, I mean, I think it's such a good point. It's sort of just baked into medicine. It's such a deep part of the culture, and it dates back to really like the beginnings of residency was initially people like lived at the hospital. I don't know if you guys had known that, but it's like their whole lives were like completely organized around this training. Like that's where they lived, and that's why I guess they called it residency. But so it's this complete like giving over of all of yourself, like every part of yourself. And you know sometimes I wonder if that's because medicine deals with life and death, and there's this really incredible dire thing, sort of feeling that comes with dealing with life and death. And I think people are on such high alert, and actually our program Thriving in Residency really highlights this and talks about how this hyper focus on life and death, which is the job, is actually like at a baseline a traumatic reaction. And so when people are operating from a traumatic place, they are more irrational, they're demanding, they're quick to anger. And I wonder sometimes if that's part of why there's such a cultural, relational sort of way of being that's that way.
I'm so sorry, just one more thing. That is so true because I just had, so I have this thing where like I have like a pre-med program. So like I host sessions with like mentees every weekend, and like I have different physicians come and talk to them. And we just had, they were like trauma surgeons that came and talked, and they were describing like their surgery rotation or another surgery residency as like going to war and coming back with like PTSD. Like they were describing it as like you come back and you just stare into nothingness and you're like, wait, what just happened? So that's how they were describing their experience in residency. So it's interesting that you said that.
That's exactly what I hear. And it's not just surgery residency, which I know is much more intense. It is, I hear that all of the time. People come back and they're just like, I mean, there's trauma to practicing medicine at that level, in that intensity. And so I think that I think what's curious is that when I talk about it that way, sometimes it scares people. And I think what's important about framing it around post-traumatic stress is that there are things you can do about that. You can mitigate the impact of trauma and actually have an incredibly fulfilling and enriching career. But when you don't do something about it, things go haywire. And so like anything that's diagnosable, you can, if you can treat it, then you can have this like really lovely relationship with the field. And so I think there has to be a cultural shift that really reframes and really thinks about it differently and thinks about how do we care for our people. So.
And what's like really mind-boggling to me is there was actually an article that just came out on Medscape on this today about how physicians, particularly those that are involved in like academics, are very resistant to any sort of change. And the reasoning why they theorize is that they've gone through all this trauma and, it's almost like they feel like they have to maintain that. And like, what a strange concept that people look back and they're like, yes, it was so hard for me to go through this, but then they feel like they need to carry that forward. Like, it's almost like you have to get this hazing to be in this position, to be like us. Yeah.
Yeah. Well, I think they don't know any other, it's almost like, I think when you're in a field for so long and it's so much a part of your identity, they don't know any other way to be. And it's hard to undo that for most. And, one thing, I'm going to make a little pitch here, which is, I think a lot of older physicians who go to treatment, who go to therapy, go on meds, which is fine if that's what they need. But I think they bypass psychotherapy and psychoanalysis and they go to the medical model of sort of treating with meds, which is, I think, a really kind of a band-aid, because what happens is then you don't treat what's actually going on psychologically. And then you can't really change, so then you see those people who are very resistant to change because they don't know any other way to function in the world. So they can't imagine anything else. So I do have a sort of my own personal pitch of, it's important to take care of our minds for ourselves and for our families and for future generations of physicians. Yeah.
I know it's after 8, but you have brought up so many points that are very validating and pertinent to my experience right now. And I apologize, I would turn on my camera, but it's laundry night at my house and there's laundry all over the place. So I am a 4th-year medical student on my sub-intern rotation in the ICU, meaning we are supposed to be treated as if we are interns. I have not been on any sort of rounding rotation in over a year since before COVID. So I was a little rusty. The first day on the unit, everyone from the interns to the senior residents to the fellow were all running around saying this attending is going to be rough. So it's her, it's not you. Just know that before you go into it. So we were rounding, and the comments coming out were even things like, what's the equation you used for this value? And I actually had it written down, and she covered it up with her piece of paper, and she said, somewhere in that small brain of yours, this equation, what is it? And what you said, one of the way to respond to it is to just not respond to it. And that's what I found myself doing. I literally just stared at her, and I didn't know, is that me kind of conceding and letting her behave this way, or is it self-preservation for me to just not give into it? And comments just continued like that. She asked me a question on another day. I didn't know the answer. So then she turned to the intern. The intern didn't know the answer. And she said, "Oh my God, you're just as bad as the medical student." And it's just day after day of that, I am finding myself just being kind of a little bit more quiet and coming home and not wanting to do as much as usual, not wanting to talk to my partner as much. So how do we address this? I need to get an evaluation from her for my grade. So am I supposed to bring these issues up with her? Or, how do you navigate that going forward as a medical student needing to be evaluated by this?
Yeah, I mean, that's such a terrible sort of situation, and also incredibly common. I think it happens all the time, and it's so sad that that's how it is. Um, because I'm a psychotherapist, I really operate, I think first of all, I think my first gut reaction was like, the system has to change, but that's not going to happen overnight. And so as really as predominantly a psychotherapist, I really operate around helping individuals find ways to navigate really impossible scenarios and like really difficult things. And so it sounds like what you did sounds like you said, like self-preservation and a way to protect yourself. And the other thought I had was, how do you deal with a bully? You stand up to them. And sometimes standing up to a bully is silence. It's not giving them anything, and they kind of back down. And sometimes that's what these people are, it's their own insecurities that are getting projected onto their subordinates. And there's so many reasons this happens. And I think some of it is that, medicine can be demoralizing when you lose patients, especially during COVID and an ICU. There's nothing they can do. And after a while, I don't think people are even aware of how much it's worn on their humanity. And then they start dehumanizing other people as a result. And so that's one way to kind of understand what might be going on and have a little empathy, but at the same time, treat it like a war zone, protect yourself and get through it. And I think that's the most useful thing I can think of to say.
I appreciate it. Thank you.
Yeah. And it's a little, oh, go ahead.
I just said thank you.
Oh, sure. Yeah. Yeah. I really enjoyed giving this talk and talking with all of you. It's really cool to you just hear your experiences and see that you're interested in thinking about the culture of this and how it's going to impact you, or already has. I will send out a link to Aquila just with my info if you guys ever have any questions and you want to reach out. Or if you want to check out our program, I have a discount link too I can send over, and you can check it out either way. But I'm available to answer any questions or talk, or or even hear your perspectives. We'd love to incorporate what you're looking for into our program too.
Thank you so much.
Oh, you're welcome. Thank you.
Yeah, thank you guys. Thank you, Ms. Iyer. It was a wonderful talk, and you really got us thinking, and great suggestions. So thank you very much.
Thanks. Okay.